Live with News 8 Now. It's going to be called a COVID reality check because we wanted to see just how we're doing in the greater La Crosse area, and we've got some great experts with us tonight. So first of all, here's a look at our panel. We've got Dr. Kevin Fitzgerald, a family physician at Mayo-Clinic-Health-System. Also Dr. Joseph Hotaruka, who's with the intensive care and also critical care units at Mayo Clinic. And then Lisa Weed, who is Vice President of Clinical Operations at Gundersen-Health-System. And finally, Dr. Todd Kowalski, who is an infectious disease specialist at Gundersen-Health-System. Thanks to all of you for joining us. Also tonight hosting is Mike Thompson. Mike.
On our website, just because of the importance of this issue right now and how it's affecting our community, especially with the holidays coming up. And we've been talking so much about the hospitals being stretched to the core right now. So let's get right into it. Could you start, let's start with Dr. Fitzgerald. Could you start by giving us an update on where we are today and where we are headed?
Yeah, I think in our community, both health systems are exceptionally busy with COVID. We have other medical issues that we care for all the time, but both hospital inpatient staff and units are really full with COVID. We've stood up our second COVID unit in an inpatient. I know Gundersen is up to 4 units in the inpatient. I don't want to speak for them, but I've heard Dr. Kowalski many times tell me that. We have patients that are in the ICU. We have very ill patients. And again, if you look at the rate of rise from where we were just a few weeks ago, we've had a significant increase in the number of patients that have been admitted to our hospitals and have needed inpatient care. I think our community right now is holding on. I think we're kind of teetering on the edge of the knife between where our staffing and our facilities can get overwhelmed by the just sheer amount of people who need hospital care and intensive care. I think if we do things to kind of blunt the rate of rise on that, we could be okay and we'll weather this. There are some things coming through in the future that are going to help turn the tide when it comes to COVID, but we are exceptionally busy right now, and really our situation is teetering on dire. So anyone want to add to that, feel free.
I can just dovetail on that, Dr. Fitzgerald. We are very stressed in the hospital, like you mentioned, opening additional units. But the problem is not only that patients come here, it's that they come here and they're sick and they're stuck in the hospital on oxygen for very long periods of time if they survive. Also, we're having problems getting patients out. Our outflow is a problem. So back to long-term care, nursing homes, back home. Counter this with the outside Northwest Wisconsin serves that we're trying to service our greater Wisconsin community. And we've had to make some efforts on small time scales to sort of provide service to our community while recognize the restraint from outside.
Also, one of you kind of described to us, just because we have people watching who are not healthcare workers, and you talked about units being open for COVID, 2 at Mayo, 4 at Gundersen. But to put that in terms of people or patients, from what I understood, and I just want to see if this is correct still today, there were about 30 patients that were COVID hospitalized at Mayo Clinic and about 50 at Gundersen-Health-System. Does that still hold true?
Maybe I'll jump in and I'll speak for Gundersen. And, you know, what I would say is, right now in our hospital here, we're somewhere around 50 patients, maybe a little bit more since I last checked. Throughout our health system, we're at over 70 patients. But it's not just that static number, that point in time number that has me as so concerned. It really is the rate of rise. So on September 1st, we had 5. And on October 1st, you know, we had 17. And then on November 1st, we had 40. And now we're up to November 1st, 40. Now in 2 weeks, we're up to over 70. So, you know, that kind of doubling rate, with the holidays coming up, that next 2-3 weeks, it is deeply concerning for where that could end.
Can I just add, what's interesting is prior to COVID, Gundersen had very high volume of inpatient cases, surgical cases and patients. So to take the high volumes that we had prior to COVID and add this on top, that's when we speak to what's stressing our systems.
Yeah, and I think in the Mayo Clinic health system, you said it right. We're right in the mid 30s right now, including some ICU patients. Mayo in the Midwest has over 300 patients. Our neighbors to the north up in Eau Claire are around 90 patients consistently over the last couple of weeks, and they're really stressed. We've heard news from Wausau and from Green Bay and from other areas in the state that are exceptionally stressed. So it's widespread. It's increasing. If it continues to increase at the rate it is, we're going to be in big trouble.
I also just wanted to extend to people who are watching on Facebook that if you would like to ask a question, feel free to shoot us a question here on Facebook, and we'll try to get that answered as well. Mike?
Well, dire, unprecedented, turning into a horror story, may have to ration care, just some of the words and phrases that we've heard from you and your colleagues over the past week or so. How difficult has it been for you as healthcare workers to get people to understand in the community the gravity of this situation? I think we all watched New York City and the tragedy that happened there earlier this year, and we kind of all thought, oh, that's not going to happen here in little old La Crosse, Wisconsin, but it kind of is happening on a smaller scale here.
Yeah, I agree with that, Mike. I think we're on the continuum towards where we could get to a place where we really don't want to be, similar to what was in New York City. And I think what Dr. Kowalski said, you know, if the trend is not turned, that's where we're headed. And really, it's facilities, but as much as anything, it's staffing. So I think we have room to expand into facilities, but right now we have 90 plus staff that are out with either with COVID or with exposure to COVID. And then by and large, you know, really the great vast majority of those are in the community, not at work. So people who are just trying to go to the grocery store, things like that, they're getting exposed. Their children are bringing it home. Their family members are bringing it home. And it's really the staffing that's at a huge risk right now.
And I can, go ahead, Lisa.
I can kind of speak a little bit more to that. Gundersen has over 500 staff out on an average basis for COVID-related or COVID-positive reasons. That's in addition to our staff that are out for illnesses, FMLA. Hardly any of them are taking vacation right now. So what we're having to do, and Dr. Fitzgerald, it is a chess game. We are taking people from IT or administration or secretaries and putting them into the roles of environmental assistants or greeters at the drive-through. Because the other thing that we've done, in addition to not having the staff, we've added all of these new services that we've never would have had before. Who would have thought that we would have had a testing drive-through or a respiratory clinic? So those are our big struggles within our walls right now.
And Lisa, you did address this partially, but I also want to throw this out to you again or others, that basically, you know, I've heard this referred to as an all hands on deck situation. And you kind of were pointing out some of the things you're having to do, which I don't think people really understand just how much you're having to stretch the talent that you already have at your different health systems just to try to plug all these holes. Do you have other examples to kind of illustrate some of the things you're having to do to meet those needs?
I'll give you an example from this morning. So our environmental assistants, that department is strapped. They have about 20 to 30 people out a day, and they are the core of our organization because they're cleaning every room as we turn over patients. They're cleaning all of the clinical areas, all of that. So we don't have enough people there. So I got a call today from the director of imaging saying, you know what, we'll take the cleaning of all of imaging and all the clinic. They'll teach us what to do and we'll do the cleaning so that they can go and clean the rooms in the hospital for our patients. This is what we're facing. We have, oh God, some incredible people that are working weekends and nights. Because of COVID, we have a higher volume of one-on-ones, and not just COVID patients, but because of what COVID is doing in the community with our mental health situation. A one-on-one is a patient that needs someone to sit beside them for 24 hours. And when we have a nurse that needs to sit by someone for 24 hours, that's one less nurse on the floor with our COVID patients. So,
did anyone from Mayo also want to just explain what you're seeing when it comes to trying to make ends meet when you don't have as many people and you have such a great need in the community?
Yeah, I mean, I'm in charge of our outpatient practices, and we're down 20 to 25% in our outpatient practice due to some people being quarantined or isolated, but also because we're drawing those people back into the hospital. So dermatology clinics, rheumatology clinics, primary care clinics, we're at less than full capacity because we're having to shift those resources down to the hospital. That means that sometimes people don't get their checkups. Maybe we can put those off. Sometimes people don't get treated for their diabetes. They don't get treated for their heart disease. They don't get treated for their congestive heart failure or their COPD. And then they have illness that makes them go to the hospital. So we're kind of borrowing from Peter to pay Paul to just do what we have to do in the inpatient setting.
I wanted to ask real quickly, are either, and
I would
I
just
apologize
jump
if this
in,
was already answered, I was having some...
that as we do that, the clinical consequences of that have been proven and they are significant. So we know nationwide that 1 out of every 3 excess deaths since March has not been COVID. It's been from other things, perhaps from delayed care, from having to have those things postponed. And as we move staff from the outpatient setting into the inpatient setting to handle this emergency, we're kicking the can down the road, and there will be consequences to that. I've shared that after the shutdown, the massive shutdown we had in March, I was in the hospital service, infectious disease service, and I saw more cases of neglected wounds that led to leg amputations than I've seen in 20 years of practice. In a few days, 5 or 6 amputations that I've never seen in either of my colleagues. And so those are the sort of untold stories that are going to play out in the future, and it's all related to what we do now.
And I will say something we've been experiencing as journalists is some people will say we're either blowing this out of proportion and even being alarmists. And that's one of the reasons we wanted all of you to be able to tell your stories, just to get people straight from the horse's mouth what's really happening in our community. In addition, geographically, La Crosse hospitals serve a tri-state area. Iowa has a near 40% positivity rate right now. And all of the Minnesota region that borders with Wisconsin have bed capacity rates of 90 to 95%. So what does that mean for our local hospitals, even trying to take patients from those areas or send patients that way?
I'll speak to that. As an ICU doc, our catchment goes far. That's a limited resource. I think we've gone down below 30% of capacity in our county here for the last few weeks. But we got to make a choice, and this is really challenging, and this is where the community can step up. Do we take people from the outside, hours away, outside of our community? Can we say no? How can we still service our community members here in La Crosse who have basic needs like heart attacks, stroke, emergent care, traumas? It's a really big problem, and it puts us in a pickle when we look at saturation from Iowa, Illinois, and Minnesota.
Do you see that as being a real possibility, though, having to turn people away?
Yeah, I mean, we have some ethical standards in medicine that we hold true to, both Mayo and the Gundersen side. But at some point, we have put forth sort of external diversion to accommodate immediate needs of the community. And it's more of a touch and go kind of thing. And it has to do with staffing and resource. But we want to be committed to the community, but also uphold our ethical standards as healthcare workers and healthcare facilities.
Can one of you address, you brought up the idea of external diversion. Some people have asked us, what happens when one or both hospitals are full within their current walls? Is there a plan to move care outside of your walls? And are your 2 health systems collaborating on that?
Todd, would you like to start off?
Yeah, sure. So what I would say is, I think both of our health systems, the rate limiting thing for us is probably not going to be the beds. It's probably going to be the people to serve those beds. And so one of the first things that happened, and these are very difficult things, but ratios start to change. If a nurse normally takes care of 2 people, maybe certainly they're taking care of 3 or then 4. And then that has some implications for quality that eventually will come to bear. But those are the kind of really hard decisions that have to get made. We, as a region, we cooperate with the state, and we've been working as community to find places for beds. But the reality is, if we don't have the people to care for them, beds aren't that helpful. And the real challenge here, as I think has been alluded to by Dr. Poderuca and others, earlier in the spring, it was just the East Coast. And so all of America could send people and resources to help be those healthcare workers to fill the gap. It's happening everywhere in our region right now. So there really isn't any help. There's no cavalry on the way from a healthcare worker perspective. We just need to do the best with what we have, and communicate clearly with our state and with each other. I will take the chance to say, it has been a real breath of fresh air that this group, I've worked with Dr. Poderuca, Dr. Fitzgerald, and the Mayo group, and to have us so aligned on serving the community and trying to do the right things, we've been in lockstep for months now. And I think that is really an advantage we have in terms of this collaboration.
I'll agree with Dr. Kowalski. I know our CEOs, Dr. Rathgraber, Dr. Mueller, talk, if not every day, nearly every day, making sure that both health systems have what they need, and that we're serving our community as best we can.
And once again, I'm just going to kind of ask, and maybe there isn't an answer right now, but winter is almost here. It's getting cold outside. Have you had to come up with a plan B for another facility if both facilities are full?
I'll speak to Mayo. Early on in the quarantine back in the spring, a lot of surge plans were created, looking at facility space, what kind of staffing we need to provide, what kind of equipment would need to occur. But really, we were really looking at the sickest of the sick, talking about ventilators and the like. And we're realizing that it's not necessarily that. It's people maybe a little bit older, maybe with health issues, that get stuck here on oxygen or respiratory support for a long period of time. So it's sort of that middle ground of not super sick, but sick enough definitely to be in the hospital that we need to get creative about. And I know Mayo and Gundersen have both created a mechanism to redistribute resources and physical space in the hospital. But what that next step looks like outside of our physical structure is unknown.
Can they hear me? Can you guys hear me?
And I would just reiterate on what Dr. Kowalski said. We can create a physical structure and find beds, but it's finding the people to be able to staff those structures. And that's what our challenge is.
Okay, and I know Mike wants to jump in here. Can you hear him?
Guys hear me?
Yes.
Okay. I just wanted to talk a little bit about the demographics. What are the demographics of these COVID patients that you guys are seeing? I know nationally it's been affecting African Americans more so than maybe white folks. What can you tell us about the demographics you're seeing locally?
I'm going to let Dr. Fitzgerald take that one because he said he could hear him. I couldn't hear him very well.
So the question was about the demographics that we're seeing in our recent surge, and I think more specifically to the hospitalized patients, what the demographics are, right. Age versus other, race versus gender.
Correct.
So I guess maybe Dr. Poderuca, you could handle that one.
So we know from the Cooley Collaborative data, a couple weeks ago it was the middle-aged group for percentage positive in the community. In the last week, it's been a little bit more of that younger group, 20s and then 30s to 40s. But on the inpatient side, it's those above 50 and then those with medical problems. In fact, 90% of those across the country that are sick in the hospital, over 90% that die, are over the age of 65. So this is a disease of the middle age. And if you're burdened with a medical issue, diabetes, COPD, heart failure, immunologic conditions, obesity, you are at risk. And this is sort of the demographic that we're seeing in the hospital. And they stay for a while. It's hard to get them out. And then it's hard to find placement ultimately.
Yeah, I think when we first had this surge, there was and still is an issue in the nursing homes. The very elderly have a very difficult time with this. And we heard from our nursing home partners that that elderly age group has a rate of death around 16% right now. So they do poorly with this. But it's not just those folks. It is people who are in their 40s, 50s, 60s, who are outside, living at home, otherwise relatively healthy with a few medical problems, but they can get really ill with this.
Patricia from Facebook.
Our experience at Gundersen has been similar. We have people from every age decade, from 30s, 40s, all the way up, typically in our COVID units. But the majority of them are a little bit more on the older side. The deaths aren't necessarily occurring in those groups, but the thing we need to be laser focused on to try to prevent is not just deaths, but healthcare becoming overwhelmed. Because when that happens, then everyone loses. Then there's more deaths from whatever it may be, strokes, heart attacks, delayed care for diabetes. And that's the issue. But the age ranges have been broad, but pretty standard with what has been seen across the nation, I think, in terms of hospitalized populations.
If I can just add, I mean, we're looking at a situation maybe by mid-December of COVID capacity saturation, and then the downstream burden of resources we cannot offer. So I'll look at Todd here, Dr. Crosse, Dr. Fitzgerald, our newscasters here. We may not be able to provide you care if you got really sick. We might have to ship you out. Or if you had your husband or your wife or a loved one or a child, how can we service them? It's those additional resources that will be strained while we try to deal with the COVID burden. And that's a little bit scary.
Yeah, and I think the other thing to just mention and really give another group a pat on the back are first responders, police, fire departments, paramedics. We have people coming into our facilities, and it's a pretty controlled environment, and we can make sure that people mask and that we clean, and that our facilities are really appropriate. We're not spreading this in our facilities because we have very good programs down. But those first responders are going into homes where it's chaotic, and they don't really know what they're getting into. And I talked to one of the paramedics the other day, and they're so busy, they have a hard time just changing their gowns and their PPE because they're so busy. So again, just a shout out to those folks. They're really part of this too. And again, think if we get half of our paramedics either ill or on quarantine, who's going to go get the people who are sick? So that we're all in this, and we're all really at risk.
I think some of the PPE is when it comes to staffing, there's obviously a limited amount, and that's going to be a problem. And it already is. When it comes to the actual PPE gear and supply need, how are your different facilities doing? Do you have what you need?
Yeah, I'll speak for Mayo Clinic. I think it's very similar in our region. We have the equipment we need. We have the PPE we need. I think, again, there are some hopeful things where we've gone. I think if you look where things were in New York City, we didn't really know how to treat these patients exceptionally well. The thought back then was we would intubate everyone on an early basis, and we found that was really not the right thing to do. And we do everything prior to intubating them, to keep them off a ventilator. But there's, outpatient therapies coming. There's antibody therapies. We're now giving steroids when people get ill and they get inflammatory lung disease, and that was not done early on. So there are things we can do to treat these patients now. But the PPE shortage that we all thought was going to be dire, at least to date, has not been an issue for the mayo-clinic-health-system.
Yeah, Gundersen, we also have adequate supplies of PPE at this time. We're careful to conserve. We're very we're still thoughtful about that. But with the time that's been bought really from March to now, we've had time to get some of our stockpiles up. I think there are some concerns that as this erupts around the nation that there could be future strains, but we're not seeing that right now. And it is really good news. So what is the good news? As Dr. Fitzgerald said, we do have data and evidence and treatments that are keeping many more of these people alive, and we're getting people better faster because of a number of the treatments that are out, and even the new one that's just coming out that we're starting to use, the monoclonal antibody bamlanivimab. And so those are positive signs, but that in and of itself isn't going to be enough. It's the behavior change and really limiting the spread that we need to get to the point of the ultimate hope, which is the vaccines, which look really, really good.
And that's a big plea here from all of us, community behavior. We've been echoing all those principles this whole time. We need the community's help right now. we are overburdened, overstressed, and we're looking to hit capacity like we talked about.
We did have a
If
question.
we can affect the number of patients with illness, the other thing with the BAM therapy and with the vaccine that's coming down the pipelines, there's going to be limited supplies, and it can put healthcare systems in really tough ethical scenarios as to how do you ration, that finite quantity of therapy, whether it's a antibody therapy, whether it's a vaccine, until we've really ramped up our facilities so we can produce enough where you can get it to everybody. But if we continue on our rate of rise, we are not going to have enough of those medicines that we're really having good luck with. We need to blunt the curve and get the overall illness in the community to be less, so we can get those patients who are very ill the medicines that they need.
We did have a question from someone from Facebook who wanted to know, would either of your facilities ever get to the point where you're going to send patients to that field hospital, as it's called, in State Fair Park in the Milwaukee area?
So I think the question was, have either facilities been where we've had to send patients elsewhere? Is that right, Mike?
Correct. I'm wondering specifically about, will you ever get to the point where you have to send patients to State Fair Park?
Oh, to the new tent, the state facility down in Madison?
Correct.
I know here at Gundersen we've not sent any patients to the state tent. What we have done, and I think Mayo Clinic has as well, is we've voluntarily slowed those surgeries that would bring people into the hospital. So we're sending those people home to not get their care so that we can manage the patients who need their COVID care. That's where we're at right now. But we haven't sent anyone to the tent. There's some challenges with that tent in terms of the admission criteria and really patients' willingness to drive. I mean, until there's literally nowhere else to go, patients aren't really excited about being 4 hours away or 3 hours away in a different facility.
I do want to make a pitch just, for Gundersen and Mayo. The hospital is a safe place despite all these scary things that we're telling you. It's essential that you still get your regular care, preventative care, vaccines, bringing your children in. That's really important to understand. It might be one of the safer places in the community that you can actually go.
Yeah, if you have an emergency, if you're having chest pain, if something really needs to be cared for, go to the ER. If you need to see your regular physician, see your regular physician. We're still able to do that, but we are being stretched.
There's a story I want to
one
tell.
person on Facebook is saying, her name is Chris. Sorry. And she's just saying that when she went out for her walk, she passed the neighborhood bar and it was full, shoulder to shoulder, and no mask wearing.
Well, there's a couple things about that I'll start with. I think the first one is one of the things that is so difficult for the healthcare workers that are stressed and strained and putting in overtime and working in shifts that are not their normal roles, to then walk by a scene like that. I mean, that is so disheartening. That is really, it's really pouring salt on the wound that as blood, sweat, and literal tears are spent trying to care for this community. Sites like that are really challenging to see. So that's one comment. The second would just be, we know from a number of studies over the 8 months of this pandemic that one of the most highly infectious environments one can be in is close quarters in an indoor environment without ventilation and without masks. That identifies what you just described. And so that's cases and hospitalizations waiting to happen.
Yeah, it's really reckless behavior right now, and again, I want businesses to be able to not go out of business. I want them to be able to make money. We should support our local businesses with carry out and whatever we can do to try to get them through this. I know there are a lot of places are in a bad spot, but if you are in an environment where you're around tens, if not dozens of people, without masks, you're going to spread this virus. And it's not unique to restaurants and bars. Right now it's youth sports. Right now it's churches. Right now it's choir practice. We've had the county tell us they've traced things back to all of those places. And they're all spreading the virus right now. Right now where we're at in our community, we should not be gathering in groups beyond your core family that lives in your household. We just shouldn't be. And we should probably not do that for about 30 days until we can get this settled down.
And that kind of leads into my next question. With Thanksgiving coming up, obviously families are going to gather, no matter how many times you tell them not to. What do you say to these people? Because a lot of people they hear you, they hear that we're in crisis here, but they're kind of thinking to themselves, well, I can take my own precautions and mitigate the risks. What do you say to those people?
Yeah, I think being in a group of multiple families, or even, whether your families or friends, if you have multiple groups from multiple homes that are getting together for Thanksgiving, it's really high risk. And again, there's no value judgment around who the virus infects. There's no value to being in a bar versus being at Thanksgiving dinner versus being in a prayer group versus being at church. They all spread this. I have elderly parents. My wife's parents are elderly. We would generally have them over for Thanksgiving. We're not going to do that. I'm going to make dinner for myself and my core family. I'm going to bring a plate over to my in-laws with a mask on, and I'm going to drop it off, and I'm going to leave. And it's just not safe to be at a dinner table with people from multiple households right now. It's not just Thanksgiving. It's deer camp. It's if you're in a small cabin or small place with people that aren't from your household, you're going to spread the virus. It's just the facts of things right now.
Hopefully I'm no longer on a delay. I guess I am. But I wanted to pass along that Denise, who's also on Facebook, just wanted to say that she's very glad that people who can tell us the truth about what is happening are doing so we can make good decisions. Also, I want to ask you, so there is a facility, a Wausau hospital, that's not affiliated with Mayo or Gundersen. They're nearly full, and their staff resources are strained. So as a result, the hospital is going to move some patients who would otherwise still be hospitalized back into home care. And they'll be relying on nursing calls and telecommunication. They'll also be asking the patient's family members to provide care. Now, locally, Mayo Clinic announced that patients are, as they're improving, can be discharged, but can return to the hospital for outpatient doses of remdesivir. And then starting today, outpatient antibody treatments are being given to those in the early stages of the virus. Can you just talk to us more about this strategy?
Dr. Poteruka, do you want to take that one? Otherwise,
Yeah.
I can. So, the patients, and I'll just speak to maybe the outpatient antibody therapy. Again, patients who are diagnosed with COVID go up to a Mayo Clinic team that takes care of all of our COVID patients throughout the Midwest. They do a risk stratification of those patients, and they decide really who's at the highest risk. Now, prior to having therapies that we could give them in the outpatient, that just meant that they were touching base with medical professionals on a daily basis to make sure they're doing well. If there's anything we can do in the outpatient setting to make sure they don't get ill to the point they need to be in the hospital, we are doing that. Now we're going to take those sickest of the sick patients and get them in for a therapy that hopefully will keep them out of the hospital. Now we have very, very limited quantities of that, and we're hoping to get more and more, but it's basically run through the state, and each health system gets only a certain amount of that. So really, it's a tough chore to choose which are the sickest patients who are at the highest risk and who would benefit the most. But that's one of the things we're really doing without outpatient therapy. The remdesivir therapy, basically the way we've done it at Mayo Clinic, these patients are stable enough for discharge. They were ill enough to get remdesivir started during their hospital stay, but they're stable to the point that we would discharge them, but we're having to keep them extra days just to get their complete treatment done. So there's doses given at certain days of that medicine. And now the outpatient therapy center can do that and free up a bed for someone else who might be ill enough that they actually need that inpatient care. Did I say that right, Dr. Poteruka?
Yeah, that's a great summary.
I would weigh in. We're as on everything else, we're pretty well aligned. We're doing a very similar strategy and very similar process here at Gundersen, where we have the outpatients who are the highest risk to develop hospitalization being set up to get the bamlanivimab or BAM therapy for short in the outpatient setting. It's a small number of folks right now. It's allocated by the state of how much we have. It's a reason for optimism don't think this is going to be an absolute game changer. You know, the studies and data would suggest at best it might prevent 1 out of every 15 high-risk patients from being admitted, and it's pretty preliminary data. But it's actually pretty amazing when one thinks about we have a biologic monoclonal antibody like this to give to patients within a year of this disease being diagnosed. It was approved in emergency use by the FDA a week ago Monday, and now our health systems are giving it. That is unprecedented in terms of turnaround speed and delivery. So there are some positive things. Again, a reason to double down. If we can just get through these next few weeks to months, I think we're going to be in a much better place.
And that's got to be incredibly hard with flu season coming up. How does that play into the role of care and the number of sick people that you're seeing?
I think the question was, how does cold and flu season play into the COVID situation, how we care for our patients?
Correct.
So I'll speak to the outpatient. Again, I'll start up front by the plug of trying to get as many people as possible to get the flu shot. At least, if we can have less flu or certainly less severe illness from flu, it'll make things less confusing as to what's flu and what's COVID, and especially, in younger people who by and large are more affected by influenza, and the elderly who are affected by both will have less hospitalizations in those groups. So if we can have less people in the hospital for influenza in addition to COVID, we have more staff and facilities for everything else. It will be confusing, and it has been confusing. Sometimes it's hard to decide what's COVID, what's not. Thankfully, our community has really good access to testing, and really some of the best access to testing in the whole country is right where we live. Both health systems have done a great job with that. I have a sister who lives in Denver. They have great healthcare in Denver. The turnaround for their test is still 4 to 5 days. We do much better than that here, and again, that's, I think, a credit to both of the health systems.
Could you talk a little bit more about the efficacy when it comes to our testing here? Because now they've recently added the rapid testing. Are any tests better than others? And even after you are tested and you're waiting for results, what should you be doing?
Dr. Kowalski.
Yeah, testing is such a conundrum because sometimes language gets in the way of understanding. So I'll speak to testing a little bit. I'm sure the rest of the team can jump in there. So when we talk rapid test, I'm gonna put another word to it: rapid antigen test. This is the kind of little card-based test. Lisa calls it the lollipop test, where you kind of looks like a little lollipop, and you put it in people's nose and rub it on a card, and you have results in 15 minutes. That's quick. That's cheap. It's not as accurate as the PCR-based test or the molecular-based test, which both health systems run for most of our patients. But when you do see surge numbers like we're seeing, it is a nice, helpful tool to get an understanding of where the disease is at. Oftentimes, we like to confirm those tests, or if we're real suspicious that it's COVID, but that test is positive or negative, we might repeat it with the molecular-based test. And then there's those other molecular-based tests, the PCR tests, the ones that are also nose swabs, but sometimes that swab that goes deeper into the nose that people don't desire, but it is a really good test. That's an excellent test, but it takes a little more of a turnaround. Anywhere from, on some fast machines, an hour. For most of ours, it's within 12 hours here on site, and that's where a lot of those are sent off. So that's the kind of tests that are out there. Testing is really good. The key is to get the test when you have symptoms, and then follow the instructions. I know both health systems have very clear instructions of what to do when you go through those testing lines, where you should be isolating, what your family members should be doing. I've seen the documents that both systems use. They're excellent. So that'd be my advice.
And I think the other thing about testing. Oh, I'm sorry. Go ahead, Lisa.
Go ahead.
Sorry, can I ask? I also want, you can throw that in too, but I want to make sure I ask Lisa Weed. You had mentioned earlier there are on any given day 500 staff who may not be able to come to work because either they're waiting for tests, or they've been exposed, or they're sick. Can you kind of explain to us, for someone who gets exposed, a staff member, what process do they have to go through in order to return to work?
So prior to 2 weeks ago, I think we went live 2 weeks ago, they would get tests just like anyone else. There are multiple tiers of testing. Healthcare workers, educators are in a tier 1, meaning that we get a more rapid turnaround. But they would have to go through the drive-through or go to Mayo for their testing and wait for the results. Recently, we changed to a more rapid test. So if we have employees here at Gundersen, we have now 2 locations where they can get tested. Asymptomatic, non-clinical person, people that don't have any symptoms can get tested, employees at Gundersen. And they get their results within an hour because it's that rapid test. Symptomatic employees go to Onalaska, Gundersen and Onalaska, a private entrance. They wait in their car, they get called in, they get their test, and within an hour they get their results. If they result as negative and asymptomatic or symptomatic, we usually let them go back to work. If it's a symptomatic positive test, we take them further down the testing route to make sure that it truly is a positive test. What I was going to say in addition to that is what I call the lollipop test, that really quick test. Those come in are very, very important when we think about nursing homes, assisted living. Up until probably a couple of weeks ago, nursing home and assisted livings were only doing testing on their staff if there was an outbreak. Now those nursing homes and some of the assisted livings are getting those rapid tests so they can at least do testing on their staff on a weekly or twice a week basis. Because it's the staff, it's the CNAs. No offense against CNAs. I have 2 young daughters that do that work, but they're bringing it in to the nursing homes. So by testing those people up front, we're actually taking care of our elderly people that are inside. Todd, would you say anything more about the testing of employees?
No, but I can't pass up the opportunity, and I know our colleagues from Mayo believe this as well, that we have had an amazing post-acute care team that has been managing these sick, ill patients in the nursing homes. We have, I heard today, 46 patients in nursing homes with COVID right now that are being managed by our post-acute care team. Dr. Liz Cogbill is a member of the collaborative and leads that work. It has been amazing work. And without their work and what they're doing to keep people out of the hospital, I really do shudder at where both of our health systems might be even right now today. Most regions don't have that kind of support or really incredible people doing that work.
Yeah, I agree. The skilled nursing facility, Dr. Cogbill, Dr. Lofi, they've done a great job.
46 patients.
The other thing I'd like to add, just before we leave testing, the one thing I would say is we've had lots of people that contact my nurses every day. They've had a significant exposure. A wife comes home, a child comes home, and so they're told to quarantine. They want to get tested, and they'd like that negative test to allow them to get back to work, to get back to what they want to do. It doesn't work that way. If you have an exposure, you may not express the virus may not become active, you may not test positive for up to 14 days after that exposure. So the quarantine is the quarantine, and there's no easy button or a negative test that can get you out of that to keep our community safe.
Thank you for explaining that.
I also wanted to ask quickly about disinformation. Obviously, it's very troubling, all the disinformation out there for us journalists, but it has to be incredibly frustrating for all the healthcare workers that are seeing this with their own eyes on the front lines. How has disinformation on something that really shouldn't be made political or taken sides, healthcare, how has that played into this whole crisis?
I think the question was, how does disinformation, how's that affected us? How do we, how do we feel about that, and what opinions we would have on some of the things that are out in the media or even on social media?
Correct.
So again, I think, I've been lucky to work with, Lisa and Dr. Poderuka and Dr. Kowalski and the team down at the county. We have experts in this area. We have science and scientists that are working on this. And again, if you spend a lot of time on social media, which I tell my children will rot your brain, you will find things in social media that are half true, not true. And really, if you're looking for your information on some of those platforms, you're looking in the wrong place. You need to look to people like Dr. Kowalski. You need to look to infectious disease specialists. Look on Ask Mayo Expert. Look to the authorities who have the scientific background to actually get the information right. And that would be my advice when it comes to this.
I also want to ask, now that you've been through this and planning for it for a certain amount of months, living it for several months, do you ever see your health systems being able to return to how they were operating before? Or do you think now you always have to have a plan in place for this kind of a situation?
Can I start this? I think that there's a silver lining to this, and it's really difficult to find it. But I think we are better now. We will be prepared, God forbid, if something happens like this. We talked about our alignment between Mayo and Gundersen and our critical access hospitals in the area and our nursing homes. We will continue to work as one and be aligned. And we have invented and found things and made things that we never thought we would make before. And that positions us to be the best for the future for our patients.
Yeah, I think we've learned lots of things from this. I agree with Lisa completely. I've talked to some of our residents and some of our students, and just, what an opportunity to be training during a pandemic. Now, gosh, really hard to find a silver lining. Again, there's been so much suffering and so much effort when it comes to this, but these are going to be our providers of the future, and they're going to be able to kind of take what they've learned during this year or two and bring it to people for the next 30, 40 years. And we're going to learn a lot of things. I'm old enough, and I might be the only one on this call. I remember going to the dentist and not having them wear gloves and not having them wear a mask, and taking the equipment and putting it in a tray of sterilizing fluid and pulling it back out for the next person. We may never get back to, certain times of year seeing ill patients without a mask. That might be, standard in the future. There are going to be some things we learn from this that are going to help us going forward. And again, Dr. Kowalski outlined having therapies and vaccines and things stood up. It's been 6 to 9 months that we've had these things come through and really utilize the scientists in the countries across the world to do this. The cooperation has been remarkable. And if you just can step back for a minute, you just marvel at that. Now, we don't have very much time to step back, but someday we're going to look back at this and we'll feel sorry for the folks that lost their life and the people that were ill. But it's going to be quite something to think about when we're old.
We won't be the same. We'll be better. And for everyone who goes through this, and for all of our healthcare workers at both places, this is our moment. This is our generational moment to step up and do things that we never thought we'd have to do. And it's our time. And so that's our message. I know over here at Gundersen, I'm sure it's the same across the street. It's hard, it's challenging, but it's our time, and we've got hope moving forward. We just got to lean into it, and we'll get there.
Is there anything the rest of you would like to share before we go tonight?
I think Martha's frozen.
The rest of you would like to share before we go tonight?
I think Martha's frozen.
Yeah, I think she asked just for any final comments from the group. Again, I can't tell you how much I appreciate being able to work with my partners over at Gundersen. I get to work with Dr. Poderuka all the time, so I'm really lucky. The cooperation between the health systems and the county has been a really great experience. I just texted Dr. Kowalski the other day. Can't wait until this is all over and maybe we can meet face to face in a different environment and actually talk about it someday. I would just tell people, listen, Start thinking of your community as a whole. Everything that you do affects the people around you. So wear your mask. I got all kinds of masks. I have 3 in my car. I have some in my briefcase. Wear your mask. Even if you don't believe the mask works, we have studies that show that masks work. Wear your mask. Try not to go to any large gatherings. Again, funerals, weddings, Thanksgiving, birthday parties, they all spread the virus. It's sad. I know we don't want to miss any of these things, but for right now, we really need to settle down our behavior, try to stay as close to your core family as you can, get this to settle down a bit, and then maybe we can open things back up. But right now, we need to change behaviors to change the trajectory of where we're going.
I would say preach it, Dr. Fitzgerald. Double down on that message.
Anyone else?
And appreciate the opportunity to really share it with the community at large.
I would just say we need your help now.
And I would also say that we're not going to give up. We're going to keep fighting and fighting for all of you.
Well, thanks so much to all of you for joining us tonight and giving us some great information, and especially for finding that silver lining looking forward. Thanks to all of you for Gundersen Health, and we also hope you can join us back here tonight at 10 on News 8 Now. Have a great evening.
Be safe.
Thank you.